Hello everyone, welcome to the first pharmacology OSPE in our OSPE series. So I'm Akash. So today we are going to discuss about an antibacterial agent. Yeah. So direct to the question, given below is a vial of a commonly used antibacterial agent in the world. So you can see on the label, it's Ceftriaxone. Name the class of antibacterial agent to which this medicine belongs to, indicating the specific generation. So you all know Ceftriaxone is a cephalosporin, and there are 5 generations uh, of these cephalosporins, in which third generation is the generation which this Ceftriaxone belongs to. So the class is cephalosporins, and the specific generation is third generation. The next question, name an infection for which this medicine is administered intramuscularly. So Ceftriaxone, you can administer in parenteral form. In parenteral forms, you have IV forms, IM forms mainly. So here we are talking about intramuscular injection. So if you remember the lecture, you will see actually there was a separate slide for Ceftriaxone indications. Here you can clearly see they have mentioned for gonorrhea they use IM injection, whereas in other infections like meningitis, community-acquired pneumonia, complicated UTI, and typhoid fever, in those cases we use IV form. Actually, there's a reason for that difference between IM and IV. We will see. Anyways, in gonorrhea, we use IM single dose, 250 milligrams. So here the answer is gonorrhea. In gonorrhea infection, that's not a infection which requires an immediate therapy and a faster response, right? What we want is a constant high antibacterial agent level in blood, which is useful to eradicate the bacteria completely. So to maintain high sustained serum levels for the eradication, we need IM. That's why we are using IM instead of IV. IV is for some faster response, right? So here when you inject the drug into the muscle, it releases it slowly, so that you can have sustained serum levels. So the answer is gonorrhea. We inject the drug into ventrogluteal side. That means the side of the hip. That's the preferred side of injection anyway. So this gonorrhea injection. So gonorrhea is the one that we are using IM injection. And the other question is, what is the other form of drug administration? It is IV. State 2 indications. So we discussed like community-acquired pneumonia, complicated UTIs, meningitis. So for those things, you can use IV. So here to remember, you can see all these except gonorrhea, meningitis, community-acquired pneumonia, complicated UTI, sepsis, typhoid fever. Those are infections which require immediate therapy. So that's why we are using IV instead of IM here. So that's the rationale between IM and IV usage for various infections. Okay, gonorrhea, IM for gonorrhea, IV for other immediate therapy requiring drug, requiring infections. So then the question: a 35-year-old woman admitted to the ward with stiff neck, photophobia. 35-year-old woman was started on this medicine, Ceftriaxone, after taking blood for culture. So that's the normal way we are doing. Ne? After taking the blood culture, we are starting the antibacterial therapy. 2 days later, the results were issued. The culture was positive for Pseudomonas. Okay. So for this part, you will have to know the antibacterial spectrum of the given drug, Ceftriaxone. So fever, neck stiffness, and photophobia, which are suggestive of meningitis. Normally, third generation cephalosporins, including ceftriaxones, are very well effective for meningitis. To be specific, bacterial meningitis. But for Pseudomonas, ceftriaxone is not effective. Pseudomonas is very it is resistant for many drugs, many antibacterial agents. Here, ceftriaxone also cannot act against Pseudomonas. So can this medicine, ceftriaxone, be continued on this patient? No, we can't, because it is not effective against Pseudomonas. Then they ask, what is the other medicine belonging to the same class of antibacterials? That means cephalosporins. To be specific, let's say third generation cephalosporins, which can be used in this situation. So normally third generation cephalosporins cannot act against Pseudomonal infections. They are good for meningitis, but not for Pseudomonal meningitis. Those are indicated for other bacterial meningitis. But there's a drug called, there's a drug called ceftazidime, which is also a third generation cephalosporin, but it is effective against Pseudomonas. Okay, that is given in the lecture also. So the drug ceftazidime is active against Pseudomonal meningitis. So they are asking for the other drug. It's ceftazidime. So remember, this is not asked in the OSPE. But remember, ceftazidime is administered along with aminoglycosides for the synergistic effect, actually, because ceftazidime is a beta-lactam which it weakens the cell wall so that the aminoglycoside can enter and it can inhibit the bacterial protein synthesis. So for Pseudomonal meningitis, you can use ceftazidime instead of ceftriaxone because it's not effective. Okay. Back to the question. Yeah, we discussed this. Name 2 laboratory investigations that should be routinely done on her to identify possible side effects. State the side effect as well. So for that, you should know the adverse drug reactions of ceftriaxone or cefixime or generally cephalosporins. So what are the adverse drug reactions of cephalosporins? And the word that you should specially note is routinely. So there can be lab investigations, but they are asking about those investigations which we can do routinely. So we'll discuss some uh, adverse drug reactions for cephalosporins. So the first one is hypersensitivity. So it is also given in the lecture, you can see. Mm, yeah, here, adverse drug reactions. So the first one is hypersensitivity. It is also a beta lactam. So just as penicillin, it causes hypersensitivity, but it's lesser than penicillin. So hypersensitivity, and the most severe form of it, anaphylaxis, thrombophlebitis, pain from IV injections, and diarrhea, because it diarrhea actually from oral preparations, because it alters your gut microbiome, and nephrotoxicity, neutropenia, thrombocytopenia, and because of thrombocytopenia you get bleeding manifestations as well. So for these things, for these thrombophlebitis, pain, diarrhea, anaphylaxis, bleeding manifestations, you can't do routine examinations that much. But to identify nephrotoxicity, neutropenias, and thrombocytopenias, you can do. To identify nephrotoxicity, you can do serum creatinine. Okay. And for neutropenias, thrombocytopenias, those cytopenias, you can do full blood count, FBCs. So, a question here: what are the lab investigations that should be routinely done on her to identify possible side effects, state the side effects? So, what are the investigations? You can do serum creatinine to identify nephrotoxicity. You can do full blood count to identify cytopenias, namely neutropenias and thrombocytopenias. Yeah, that is that about cephalosporins, mainly ceftriaxone and ceftriaxone. Okay, thank you very much.